So, first case, patient came in, there was no bone on the buccal, and as I mentioned, always the mandible is slightly lingually inclined, and there is loss of some vertical height, as you can see in this CT scan. So after laying flat, I can appreciate there is no bone at all at the buccal surface, and I will make osteotomy. Here, my crestal cut should be done about 10 millimeter in depth, and also my vertical cut, mesodistal vertical cut, should be about 5 millimeter deep to ensure that I cut all the way to the cortex. Now, the flap management is also very critical, and as you can see in this picture, there should be no periosteum, and the flap should be very clean in that you can see an intact periosteum on the buccal flap. This is very important because even after doing ridge splitting, I always recommend putting a bone graft or at least a membrane to cover the splitted ridge. And you will see why I do this later on in the presentation. And in order to do this, you should not have any soft tissue, you should not have any periosteum in the buccal plate. So I utilize piezo art from Duel. It's a very good piezo machine. The blades are very fine and thin, so therefore you can really preserve the residual ridge. And also the power of this piezo is incredible. It's like using a saw, and you can really cut the ridge very, very fast. Now, typically in any ridge implant system, in order to place a 4.0 implant, we need to drill to 3.3 drills at least. Even in some high density bone, for this particular implant system, sometimes you need to drill to 3.8 in order to put a 4.0 implant. However, when we are splitting the ridge, I do not recommend drilling all the way to 3.3 or 3.8. In fact, I recommend using just the lens drill and a 2.0, that's it. Now, you may need to put 2.9 drill just about 3 millimeter into the osteotomy, no longer than 3 millimeter, because if you make too much osteotomy in terms of diameter, then you cannot split the ridge. You will not have a great of a splitting effect. Therefore, I always recommend undersizing the osteotomy, and depending on how much you undersize, you will have a greater effect of a splitting, ridge splitting, and less drilling you do, more splitting you will have. Here, once again, I'm utilizing any ridge implant from Megagen, and initially, you will only be able to put about 3 millimeter into the ridge, because my 2.9 diameter drill was only into 3 millimeter. So after we do this, we will utilize ratchet to slowly insert the implant, and as you slowly insert the implant, you can see the displacement of the buccal plate, and deeper you go with undersized osteotomy, you can displace the bone more buccally, as you can see in this picture. Now, after splitting the ridge, my buccal plate is actually even with the adjacent ridge, and my implant position, I'm very happy because it's in the central fossa, and as you can see in the mandible, this is the very easy and predictable way to split the ridge. And this will induce a green stick fracture. And by the way, it is very important to note that I did not make any cut in the apical portion of my ridge splitting. As you can see here, you can see a green stick fracture at the apical portion of the mandible. And if you make a cut, if you make even a groove, there is more chance to break this buccal plate. Therefore, I do not recommend making apical cut at all, not even making a groove. I like to induce this green stick fracture by slowly inserting the implant. And by doing this, I can maintain very good stability of implant, and my buccal plate does not move at all. Once again, if you make a apical cut like some literature shows, there is a greater chance to make this buccal plate too loose, thereby losing everything. And I do not recommend making apical cut. So I like to augment some bone, especially in the corners, not so much inside the sandwich, but I like to put the bone graft at the edge of the bone to reduce the sharpness, and I always use membrane. Bone graft is not very important, but use of membrane is very, very important. And carrying primary closure always helps, but not really required in this technique. Sometimes I will put a healing abutment. Now, when you see the PA here before and after, you can appreciate that I gain even the height of the bone, because, as I mentioned earlier, because the cortex is lingually inclined by 20 degrees. When we split the ridge, always the buccal plate becomes a little higher, and we gain 1 to 2 millimeter of height when we do a ridge splitting in the mandible. So this is a post CT scan before and after, and you can appreciate that we induce the green stick fracture and we have gained the amount of buccal bone. And I recommend minimum of 2 to 3 millimeter of a buccal plate in order to have a good longevity. Therefore, if you have a too narrow ridge, when you split the ridge, you will see after 3 to 4 months, you have lost that buccal plate because it was too thin after splitting the ridge. So minimum dimension, I recommend 5 millimeter in order to do this technique. So why am I putting a bone graft or membrane into my site? It's because of this animal study that I read by Dr. Han in 2011. And here, after splitting the ridge, he compared just the bone graft alone and just bone graft and the membrane, or just the blood clot. And to make the long story short, in this literature, he found that by utilizing bone graft and the membrane, he saw less resorption and he saw the maximum gain of the bone to implant contact and less marginal bone loss. In contrast, if you just use blood clot, he saw about only 33% of bone to implant contact compared to 39% in group 3. So I recommend putting putting a bone graft and the membrane when you're doing this mandibular ridge splitting technique, in order to increase the bone to implant contact and reduce the marginal bone loss. So let me show you another case to show this one-stage mandibular ridge technique, and this is more of a borderline technique, a borderline case, because the ridge was much thinner than 5 millimeter, and this case was referred to me from a friend of mine, and she described that she placed this implant, but patient developed paresthesia. So she called me up and she asked me what should she do, and I recommended to remove the implant. Now, fortunately, after removing the implant, the paresthesia went away. So patient did no longer have a paresthesia, but after putting a shorter implant, she should have really put wider diameter implant, but she didn't, and implant failed again. So after 2 surgeries, patient was referred to me, and when I saw her, patient had a very minimal buccolingual dimension. Now, the patient didn't want to have multiple surgeries anymore, and patient asked me, can you put this implant with only one surgery? As I mentioned earlier, because of very limited buccolingual dimension, I prefer doing a 2-stage approach, which means doing a GBR and then placing an implant later for this particular case. But because there was 2 failed surgeries previously by my colleague, and patient did not want to have multiple surgeries, I chose to do a ridge splitting for her case. So in here, we can appreciate very narrow buccolingual dimension, and when I lay flap, the crestal portion was very thin. Now when I make incision, I use multiple blades. In the crestal incision, I like to use 12 blades because of its curvature, it really allows me to make incision at the distal end of bicuspid all the way down. If you use 15 blade, you will not be able to cut the very distal end of number 29. So I recommend using a 12 blade to make incision, and I utilize 15C blade to make a circular incision, and I always use fresh blade, and when I do surgery I have about 3 or 4 blades in my table because I like to use many new blades. So after making incision, we'll make a full thickness flap, and I use multiple blades as you can see here. Whenever the blade touches tooth, I will pick up a brand new blade. So I'm making incision. So after we make incision, almost always in the mandible, the base of the bone is wider than the crest, therefore making a ridge splitting more favorable, as I mentioned earlier. So here I will utilize piezo machine to make a crestal cut. When I make this crestal cut, I am going 10 millimeters in depth, and when I make vertical cut, you need to stay at least 2 millimeters away from the adjacent teeth, and I will go in about 5 millimeters in depth to ensure that I cut all the way to the cortex. Now this cut is very important. If you do not make a very sound cut, when you split the ridge, you will not split the ridge. In fact, the bone will fracture at the crestal portion. So I recommend making cut all the way to the crest, and please make a definite cut. Always in the mesial portion, you will have a very pronounced ridge splitting effect. On the posterior, because of buccal shelf, you will have less pronounced ridge splitting effect, but that's okay because we are still maintaining minimum of 3 millimeter of buccal plate. Now, as you can see, this particular piezo is awesome because it has a LED light, and this really increases visibility to my surgical area. So I really like this piezo machine from Duell, and rapid movement, as you can see here, is very critical. Please don't stay in one area, and please keep on moving back and forth as I'm doing here to decrease amount of heating of the bone. So this is very important concept to know. So as you can see, these corners is very important area, because if you don't make a cut in these corners, if the cuts don't merge together, you will not have a good ridge splitting effect. Therefore, I recommend even cutting over a little bit and overlapping the crestal and vertical cuts so that you have a definite cut, allowing the displacement of buccal plate. So I am now making vertical incision, and once again, you need to stay at least 2 millimeters away from the adjacent teeth, and please move back and forth very rapidly, reducing amount of heat to your height, to your bone. So once again, I'm moving back and forth, and it's not so much how hard you press, but how fast you can move. Will cut the bone much faster. So after I make that cut, now I will drill, once again, lens drill, which is very sharp, as you can see here, and I will use 2.0 drill and 3 millimeter of 2.9. Typically for 4.0 in mandible, sometimes you need to use 3.8 or 3.3 depending on the density of the bone, but in this technique you're going to stop at 2.0 and then 3 millimeter of 2.9. And by undersizing the osteotomy, it will induce the splitting effect of the mandible. So here I'm using lens drill with a lot of irrigation. Now this drill will pretty much determine the location of this implant, so you need to look at from multiple angle. And if you have lingual concavity, you need to lingually tilt the burr so that you don't perforate the lingual cortex. And when I do this osteotomy, I look at from every angle, making sure that I like my position and angulation. And I don't go all the way in one step. I will go a little bit, stop, and then I will go a little bit more and stop. Doing this in 3 steps. Sometimes you need to rotate the handpiece because you will the tooth in the front will prevent you from drilling further down. Or you can use drill extension, but sometimes you have a patient with limited opening and you need to rotate the handpiece. So I'm using 2.0 twist drill, and as you can see here, I'm going a little bit in, stop, little bit in and stop, and doing this in 3 to 4 steps to minimize hitting of the bone. So after I go into a 10 millimeter in depth, I will use 2.9 drill, and once again, this drill is only to introduce the apical portion of the implant into the bone, and it's not so much to make the osteotomy, it's just to make opening of the bone, and I only drill to 3 millimeter in depth. So this is how it looks like after I do the osteotomy. We have a very small opening, but below the 3 millimeter in depth, the osteotomy is only 2 millimeter. So I will utilize any ridge implant here, which is a taper implant and very aggressively threaded implant shape. The apical portion is about 2.7, therefore we need to utilize 2.9 drill to introduce this implant into the osteotomy. So here I will slowly insert the implant. So it comes in very nice capsule, and I pick up the implant with the handpiece. After picking it up, I will slowly insert the implant at the maximum torque, and when the machine maxes out, I will use the ratchet to insert the implant very slowly. So this is the implant. You have to ensure that your implant does not touch any saliva, because saliva, as we know, is not the sterile environment. We have lots of bacteria. So if my implant touches saliva, I will open a brand new implant and do this again, because I would like to use a very sterile implant. So slowly I will insert the implant, and when it maxes out, like in here, it maxed out about 4 millimeter into the osteotomy, I will pick up the ratchet, and once again, in the medial portion, you have a great ridge splitting effect compared to posterior area later on as I am inserting this implant, because of buccal shelf, the posterior region, you don't see as much ridge splitting effect. So this is a mistake. You have to ensure that your assistant retracts the tongue and keeps the implant sterile. Although there has been some interesting studies where they put implant into a dog, the implant that was exposed into oral cavity for a long time, and they have shown in histology that those implants still integrate. However, in my patients, we have to do everything we can to decrease the contamination of implant. So I will slowly rotate my ratchet very, very slowly If you have too much resistance, then I recommend going back and making a final cut with the piezo. And you shouldn't feel more than 100 newtons per centimeter when you are doing this rotational movement. So after we do this, now we can see a great rigid splitting effect, especially on the mesial. You can appreciate that. And this is a very easy way to gain 2 to 3 millimeters of the residual ridge. And after we insert the implant all the way, we'll put the healing cap, and I will utilize collagen membrane. In this case, I use Lyoplant from Braun to decrease the sharpness at the edges, and also to decrease the resorption of my buccal plate and increase the to maximize the bone-to implant contact, according to Dr. Han in 2011 animal study. So now all I need to do is just suture. No periosteal releasing incision is required to get primary closure in the mandible, as long as you reflect lingual flap and the buccal flap all the way down, then you will not have any problem getting primary closure. Now, I did forget to mention that when you lay flap, please be careful about mental foramen, and I always identify the mental foramen when I do this procedure, because that way I know exact location of an inferior alveolar canal. So I recommend identifying the mental foramen. Therefore, you can surgically know the location of inferior alveolar nerve, and therefore your vertical cut should be at least 2 to 3 millimeters away from the estimated inferior alveolar canal. So once again, no periosteal releasing incision was done, and you can always achieve good initial stability, good primary closure without periosteal releasing incision in the mandible. So this is the outcome, and this is a very important step, more important than suture. Making sure that you press down on the flap for 3 to 4 minutes, and making sure that there's no sharp edges in patient's bone. So this is X-ray right after. We should stay at least 2 to 3 millimeters from the inferior alveolar nerve, and your vertical cut should not impinge on the adjacent PDM. So thank you very much for watching my video. I hope that I have influenced some of you to do more minimally invasive and more easy and predictable ridge augmentation technique. Thank you very much. If you have any question, please send me an email, samnidds@yahoo.com. Thank you.